So you do all of your initial things on this, you know, introduce yourself, ensure appropriate draping. If it's a female, for our purposes, you can use the gown, or you can ask them if they have the sports bra, if it's okay to just do it that way, so then you're not, you know, maneuvering with the gown. You'll want to wash your hands and wash that stethoscope with alcohol right after you take that blood pressure cuff off of them that's been on 900 patients before them, but it's all good though. All right. But first thing you'll do is after you introduce yourself is go around and get from a central point in the back so you can see everything really well, and you know, you're inspecting for symmetry, anatomy of expansion, contour, any skin lesions, any central cyanosis, and I see none. Then we'll go to palpation. I'm going to check for chest expansion. Okay, go ahead and take a deep breath in. And as you can see back there, the chest expanded equally bilaterally. So chest expansion was symmetric. Next, we're going to palpate for any masses or tenderness. Any of that tender back there? Oh, okay. All right, good. And next, we're going to palpate with tactile primitus, checking for any impedance of the vibration. And so what I'm going to do is I'm going to put my hands on your back, and each time I move them, I want you to say 99, okay? Yep. All right.
99. 99. 99.
Okay. Tactile primitus was equal bilaterally. There was no increase in vibrations. So next we're going to move into percussion, and I'm going to percuss the lung fields for resonance. And so okay, all the lung fields are resonance to percussion. Now we're going to percuss for diaphragmatic excursion. And the first thing, if you could for me, please take a deep breath all the way in and hold it. Okay. Okay, let that breath all the way out. You'll mark that right there, okay? Up. Okay, you can breathe normally now. If you're one of the people that takes too long, you can let them have a few breaths in between, you know, as when you go all the way down and back up, so they're not starving for air. But if you do it that quick, they ought to be able to hold their breath that long. Then you'll measure that, mark it, and you'll do the same thing on the other side. I'm not going to do that, but you will. And you'll say diaphragmatic excursion is 5 centimeters on the right and left, or is equal bilaterally, something like that, okay? All right, so now posteriorly we're done with percussion, and the next thing we're going to do is auscultation, right? So we'll auscultate the back in the same areas that we perform percussion. So each time I place the stethoscope on your back, could you take a breath in through your mouth a little deeper than normal, okay? Yeah. All right. And out, in and out. So either lungs were clear to auscultation, or barosounds were versicular, or there were no adventitious breath sounds heard. One of those things, okay? So now we finished with that. Come around to the front of the patient and do the same thing, inspecting for symmetry of anatomy, expansion, contour, AP to lateral diameter, any skin lesions, any central cyanosis, and there appears to be none. And then again, we'll move on to palpation now. First thing I'm going to palpate is for chest expansion. So take a deep breath in. Okay, chest expands equally bilaterally. Now we're going to palpate for any masses or tenderness on the chest. So Okay, there's no masses or tenderness noted on palpation. We're going to do tactile fremitus again. Each time I move my hands, say 99, okay?
Yep.
All right.
99. 99. 99.
Okay. There was no increase vibrations on tactile fremitus. So the next is going to be percussion, and we're going to percuss the anterior lung fields. So I'm just going to be tapping on your chest a little bit, okay?
Mm-hmm.
Okay. The lungs are resonant to percussion, and now we're going to auscultate. And we want you all to auscultate the apices. And when I do that, you'll see me flip it around to the bell. There's no reason to do that for sound purposes. The only reason I do it is because it just fits in there. The diaphragm, I mean, if you try to put it over the clavicle, it's kind of raised up, you know? So take a deep breath in again, a little bit more than normal each time I move it. There were no adventitious breath sounds. All the lung sounds are vesicular. And so now, if all those findings that I did on those exams had not been normal, if there had been any increased transmission on tactile fremitus or any dullness to percussion where it was supposed to be resonant, or any wheezes, crackles, or whatever to auscultation that wasn't supposed to be there, then these next tests are special exams that you can do to try to help you confirm your suspicion that something is abnormal in that area. So one of those tests is called bronchophony, and what we do in that is, had there been an abnormality here, I placed a stethoscope on there and have the person say 99.
99.
And do it again. You can check it
99.
bilaterally to compare sides.
Oh.
Yeah. So what should happen if there is nothing abnormal there is it should be indistinct and muffled. Had the sound been increased and clear, that would have been positive bronchophony, and it would have added evidence to my initial finding that there was something other than air-filled lung there. Okay. The next test we can do is called egophony, and it's done the same way, it's just what they say is different and the result is different. So you put the stethoscope on and you have the patient say E.
E.
Do it again.
E.
Okay. Again, indistinct, muffled is a normal finding. Doesn't support your other findings. If the E would have changed to A, that would have meant positive egophony, would have meant that there likely is something there that when you heard it on auscultation or percussion or whatever. Okay. The next test is whispered pectoriloquy, and in that one you have them whisper 1, 2, 3, and again it should not be clear, should not be very, very distinct, should be almost not heard at all. Okay, so 1, 2, 3. Okay, so that was a normal finding as well. Is that it?
Yeah.
Okay. Cut.